those that had microsatellite instability or a deficient mismatch repair system that were hypermutated, those that were copy number low, so kind of the more traditional endometrioid histology with no specific molecular profile, and then patients that were p53 aberrant and had high copy number, most commonly the serous cancers. Now, what's important when we're using this subclassification is that not only do we have to do biomarker testing for either of these categories, but you have to do it sequentially so that you're assigning a patient the correct category. And on the left-hand side, you'll see the PROMIS classification, which is the algorithm that we use to help understand which patients go into which subtype. The important thing is that you have to do it sequentially. So ideally, with a new sample, you would do POL-E testing first to see if they're hypermutated. If they aren't, then you would do mismatch repair deficiency testing through immunohistochemistry. And if all those proteins are normal, then you would do p53 immunohistochemistry to determine if they were a p53 wild type or p53 mutated. And that's how you get the 4 classifications. I think one thing that's important to understand is if you don't have that initial POL-E testing, then some of the downstream changes, like mismatch repair deficiency or p53 aberrant, could be related to the POL-E mutation and may not be a true classification into those subtypes. And what we've also learned is that each of these subtypes is also associated with sort of overall survival in response to therapy, with the POL-E patients doing significantly better and the p53 aberrant having the worst survival. So what's other information about these 4 categories? Again, for POL-E, depending on the study, it makes up about 7 to 10% of all endometrial cancers. Generally, there's a favorable prognosis. If you look at most studies, the risk for recurrence or death from disease is extremely low, if not 0. They generally are good candidates for immunotherapy. Many have an endometrioid histology, but again, because they have sort of all these mutated genes, they may have p53 abnormal expression or loss of mismatch repair, but they're not truly in that category. Next, we have the MSI high tumors, which categorize about 25 to 30% of endometrial cancers. These are often a result of hypermethylation of the MLH1 promoter. A subset, about 3%, are due to Lynch syndrome. And as we know, immunotherapy or immune checkpoint inhibitors are standard of care in this patient population. We then have copy number low or no specific molecular profile. And I would say this is sort of like everyone else that doesn't fit into the other 3 categories and is probably still somewhat diverse, but makes up about 50% of endometrial cancers. They're generally microsatellite stable. They're usually endometrioid. Some are ER/PR positive, but the beta-catenin, PI3 kinase pathway abnormals are also in this category. And again, I think probably of the 4 subgroups, this is still the most heterogeneous, and I think we're learning more and more about this group. And then finally, we have the p53 abnormal, or the copy number high, which is typically the serous high-grade histologies that generally have the worst prognosis. Now, when we look at biomarker testing for endometrial cancer, it's really important to understand the type of testing that we're doing as well as the timing. And I would say each of these subclassifications are things that we often are doing now at the time of diagnosis and not necessarily waiting till patients recur. So in regard to immunohistochemistry, in my practice, we do ER/PR on everyone. We look for the mismatch repair proteins, so MLH1, MSH2, MSH6, and PMS2 at the time of diagnosis. We also look for p53 on immunohistochemistry. For specific subtypes like high-grade serous or carcinosarcomas, we also do HER2 immunohistochemistry. In some populations, if the HER2 is equivocal, so 2+, and you're looking at sort of the breast classification, then you can do HER2 amplification to look and see if they're FISH positive. That helps determine whether they're a candidate for certain types of treatment, and I know Dr. Backus is going to go into that into a little more detail. MSI testing can also be done by PCR. I think we know that immunohistochemistry for the mismatch repair proteins, it has a higher sensitivity, so that's often what we do first. If it's unclear, then we may go on to do MSI testing. And then if someone has loss of staining of MLH1, we reflex test for MLH1 promoter methylation to determine if it's a epigenetic process or whether they could have a germline mutation. And then finally, next generation sequencing to look at the mutation analysis of tumors. So many profiles include POL-E testing now. They didn't a few years back. And so there is an option to do Sanger sequencing on POL-E if you're just looking for a single gene. Now, I just wanted to point out that because this molecular profiling has become more prevalent in sort of how we treat patients, how we classify them, how they qualify for trials, these tests are all mentioned and recommended in the NCCN guidelines. And one of the main reasons we put it in the guidelines is to not only make sure people are aware how important the testing is, but also to help with insurance coverage and actually paying for the testing. Because not all of these tests are easy to get depending on your practice location and kind of your clinical practice. I think I just wanted to point out that even in the TCGA data, it showed that all of these profiles are associated with prognosis. Even if you look at large endometrial cancer studies looking at different outcomes, the subset analyses of these studies, for example, PORTEC-3, also show that their molecular subtype is associated with both recurrence-free and overall survival. So it's consistent across other studies. As many know, in 2023, the FIGO staging for endometrial cancer was updated. Probably, I would say most think prematurely, but I just wanted to highlight that the molecular testing now is included in the new staging. Again, emphasizing why it's important for all of us to do this in clinical practice so that we can get more information on stage and prognosis for patients. So the first polling question is, what is your clinical current practice for molecular testing at the time of diagnosis for a low-grade endometrial cancer? Number one is, do you do IHC for ER and PR only? Again, low grade, so endometrioid grade 1 and grade 2. Do you do immunohistochemistry for the mismatch repair proteins only? Do you do ER, PR, and mismatch repair proteins? Number 4, do you do the whole pro-mis classification, so POL-E, mismatch repair, as well as P53 IHC? Or 5 would be, there's no standard at your institution. Okay, so it looks like there's a third of the group that doesn't do any testing, which I think hopefully we can convince you to do otherwise after our talk tonight. And then it's kind of broken down. So some just ER, PR, 6% looking at mismatch repair proteins only, and then the remainder looking at some combination of other testing. So now, same question, although the answers are a little bit different, for high-grade endometrial cancer. So the high-grade serous, carcinosarcoma, grade 3 endometrioids, ER, PR only, mismatch repair only, a combination of the two plus P53, or number 4, kind of a full panel. I did add on here HER2 because I think for carcinosarcomas and for high-grade serous, there's a clinical indication even at the time of diagnosis that we'll get into in a second, or none. Okay, so it looks like, understandably, in sort of these higher risk or higher grade tumors, more people are doing some type of testing, which I think is great. And about 50% looks like we're doing kind of panel testing. So that's great to know. So why is this important? I think what I wanted to highlight, and I know Dr. Backus is going to go to clinical cases and scenarios, is that right now there are standard of care upfront therapies that are affected by this molecular testing, which is why it's so important to do it at the time of diagnosis. Here just shows the 4 progression-free survival curves from randomized prospective trials looking at Taxol carbo versus Taxol carbo plus an immune checkpoint inhibitor. And as you can see, in patients that have a mismatch repair deficient tumor, the studies all consistently show a benefit. So it's in patients with advanced disease, patients with measurable disease, patients with surgically resected disease, chemo-naive, platinum-sensitive. So I think this is why it's important that in all comers with mismatch repair, testing is done up front because it should impact the standard of care treatment that you're giving. A second scenario where the molecular testing up front can impact your testing or your treatment is in patients with advanced uterine serous cancers. This is a prospective randomized trial looking at patients that are HER2 positive. And in this particular study, the HER2 testing was using the breast classification. So immunohistochemistry, if it's 3+, they were considered positive. If they were 2+, they were considered equivocal, and you had reflex FISH testing. If that was positive, they were then eligible. And as you can see, the addition of trastuzumab to Taxol carbo, followed by trastuzumab maintenance, improved both progression-free as well as overall survival in these patients with a high-risk advanced disease. So again, an important reason to do this testing up front. And then the last thing I wanted to highlight before we look at ovarian cancer is the Destiny Pan-Tumor trial, which looked at also HER2 positive cancers. There were a number of different cancer types tested. On the left in the highlighted area is endometrial. It's important to understand to classify for this study, it was done based on immunohistochemistry using the gastric scoring system, so it's a little bit different than the other indication. And patients were considered eligible if they were either 2+ or 3+. And in the patient population with endometrial cancer, the overall response rates were about 58%, so quite nice in patients with recurrent disease. And those that had 3+ tumors had over 80% response rate. So again, it's important not only to know that you're looking at a HER2 targeted drug, but how this designation was made based on the trials. Now, if we switch briefly to ovarian cancer, I would say we're not quite as far in how we use molecular testing to determine primary treatment for ovarian cancer. But the big thing is genetic testing. So as you probably all know, when patients present with advanced stage ovarian cancer, the primary treatment is a combination of surgery plus chemotherapy. Many women were able to get cancer-free. So response to chemotherapy is about 70–80%, but the risk of relapse is very high. And so there's been a number of trials looking at what can we do to add therapy in the beginning to improve patients' progression-free and overall survival. And right now, genetic testing is the key. So it's important to understand the difference between both germline and somatic mutations and BRCA or other mutations. Germline mutations, as I described to patients, are passed on from patient or from parent to child. They're abnormalities in all of your cells that put you at higher risk for cancer. And then somatic mutations are mutations that develop in the tumor itself. Both of these, though, have implications for treatment for patients with ovarian cancer. What genes should be attested? Well, in women who have a new diagnosis of ovarian cancer, the 4 major clinical guidelines all recommend genetic testing for everyone. And this includes BRCA testing for BRCA1 and 2, the less penetrant genes like RAD51C, 51D, BRIP1, and PALB2, and then also Lynch syndrome, which does increase your risk for ovarian cancer about 10–14%. The other thing that's important to understand, it's not only these genetic tests that lead to homologous recombination defect, but there are other factors as well. And so if you look at all ovarian cancer patients, about half are characterized by homologous recombination defect. And again, this should have implications for their primary treatment. What is also important to recognize is that even though genetic testing and molecular testing is recommended sort of universally by all of the societies, we're not that good at it. Okay, so this study was published just a few years ago. It was a meta-analysis looking at kind of the uptake of genetic testing for patients with early ovarian cancer. Hopefully we were doing a better job now, but it was only about 40%. And if you look kind of across different patient populations, there are subpopulations where the testing is even less done less often. So again, something to remember to do and is very important. There are different testing paradigms. So there are situations where you test the tumor first. If the testing in the tumor is positive, then you can move on to germline testing. Some people do germline testing first. If germline testing is negative, then test the tumor. And then there's also paired testing. And not only do you want to test for the genes, you also have to do HRD testing of the tumor to really understand the implications for treatment. And I'm going to sort of hurry up because I know we have a lot to talk about. There are a number of different tests out there for HRD. I think they haven't been directly compared, but I think whatever platform you're using, it's important to understand the testing that's done and the scoring system so that you can correctly interpret the data. And I think I would just remind yourself that these tests are always evolving as we learn new information. Again, implications for treatment, and this is my last slide. Across different studies and different patient populations, for patients that either have a BRCA mutation or are HRD positive, the data has been very consistent. So the addition of a PARP inhibitor as maintenance therapy and frontline treatment has significantly improved progression-free survival, particularly in BRCA patients, but also in patients with HRD, like non-BRCA HRD. And I'll just stop there because we'll keep going. Okay, so those are, I could talk forever. Okay, so we're gonna go ahead and turn it over. And so Dr. Backus is gonna move on to the endometrial cancer cases.
I got my own. Great, that was a great introduction. I'm excited to talk about this for advanced endometrial cancer. We have a lot of different scenarios in here. And I wanna start off by saying, showing you a little bit about the drug approvals for endometrial cancer. For the longest time, we just had Megestrol. And for almost 40 years, we added nothing to it. And so finally, we got an approval for pembrolizumab when immunotherapy started coming up for mismatch repair deficient recurrent endometrial cancer. And then we added several other immunotherapy agents, added lenvatinib and antivascular TKI. And then most recently here also, we see that the HER2 targeted drug, like you were just mentioning, trastuzumab deruxtecan, has been added to this list, although that's not a full approval yet, it's accelerated approval. So lots of great new options. And really that molecular testing that you were talking about is becoming so important for making our treatment decisions, as we'll see in some of these cases. So this case of this patient is going to be the same case, but we're going to vary the molecular profiling a little bit. So this is a 55-year-old diagnosed with grade 2 endometrial cancer. She just underwent surgery with staging. Final pathology confirmed this. She ended up with having a stage 1B endometrial cancer. She was ER/PR positive, mismatch repair protein. She showed loss of LMLH1 and PMS2 with hypermethylation. And then post-operatively, she received vaginal brachytherapy. So the first question here, so now 18 months later, she develops a multifocal lung recurrence. Tumor biopsy confirms that she still has a grade 2 endometrial cancer, but now metastatic to the lung. The tumor is mismatch repair deficient, HER2, 2+, FISH positive. What would you recommend at this point? The options are going to be the same, so I won't read to you with every scenario, but let's start off with number 1 is platinum-based chemotherapy. Number 2, platinum-based chemotherapy, so carboplatin, paclitaxel with bevacizumab. Number 3, with immunotherapy. Number 4, you're going to give her single agent immunotherapy. Number 5, platinum-based chemotherapy with trastuzumab. Number 6, lenvatinib pembrolizumab. Number 7, trastuzumab deruxtecan. Or you give her hormonal therapy. All right, great. So the majority of here in the audience or at home said platinum-based chemotherapy with immunotherapy, but there was some trastuzumab out there, kind of a variety of all different things. So let's look through this. I think in my mind, at least for this patient who now has her first recurrence, who has previously been untreated, and she's mismatch repair deficient, we were all blown away by these graphs. When this got presented in 2023, I think we'd never seen something like this. A hazard ratio of 0.28, 0.3, so a 70% risk reduction in the risk of cancer recurrence or death was amazing. And so in all these trials that have been done, and more are here, but the 4 main ones are here, the Ruby trial, DUO-E, Energy GY018, and a 10 trial, all showed a similar hazard ratio of about that 70% risk reduction or a hazard ratio of 0.3. So huge benefit here of adding immunotherapy. So that would be really the first choice there. And now we even have some overall survival data for this recurrent mismatch repair deficient population. On the left, you see the RUBY. And this overall survival data is despite a 60% crossover. So even though those patients in the placebo arm, 60% of those received immunotherapy in later lines, they were able to maintain this survival benefit. So the earlier we use this immunotherapy added to chemotherapy, the better it is really. In GY018, we still see a hazard ratio of 0.55, but this trial was unblinded and there was very early on crossover, so much more difficult to show that survival advantage in this study. We've also seen a combination of immunotherapy with a PARP inhibitor in RUBY Part 2 and in DUO-E. We see here that there's a similar benefit again of adding the immunotherapy, but on the graph in the top on the right, we see that in a mismatch repair deficient, the addition of a PARP inhibitor, which is between the green and the blue lines, we don't see much difference here. So it's likely just the immunotherapy, and the PARP doesn't, it's already so good, you can't really add a whole lot more. So talking a little bit about side effects of immunotherapy, this is between the three of the approved immunotherapy agents for mismatch repair deficient recurrent endometrial cancer. And this is for the combination with chemotherapy. So we see AEs in almost every patient, grade 3 or higher in about 2/3 to 75% or so. Fatigue, alopecia, nausea, chemotherapy, the myelosuppression. We see those with all of these. We see some diarrhea, rashes that may be more contributed to the immunotherapy also. Unfortunately, we don't see a whole lot of grade 3 side effects. It's important to remember that any organ can be affected by immunotherapy and the side effects of this, and this is just kind of going throughout the whole body. Any vague side effect can be related to immunotherapy and requires a workup and certainly close monitoring. And this can start within the first week, and it can go up to a year or sometimes even longer. So important that you keep these on your radar. So we have to educate our patients and the caregivers about the signs and symptoms of side effects associated with immunotherapy, and continue to monitor these patients with a general blood work, thyroid function testing, are really all we can do, and then symptom-directed investigation if we think that there may be something happening there. When you see these immune-related side effects, we typically continue to treat when it's still a grade 1, although sometimes topical steroids, specifically for skin-related adverse events, can be used. For grade 2, we'll hold the drug and typically start a steroid with oral steroids between 0.5 and 1 milligram per kilogram prednisone per day. And sometimes that may need to be changed into IV. For grade 3, yes, absolutely hold your drug and start high-dose steroids. And sometimes you may even have to add additional agents to this. Those steroids should be tapered over 4, but sometimes longer, 6 to 8 weeks even. If the side effect improves back to grade 1, you can talk to your patient about restarting, but of course that also depends on what AE it is. Certainly not for the myocarditis or demyelinating adverse events. In that case, we would favor not restarting. Okay, so let's switch gears a little bit. So what if this patient with that multifocal lung recurrence had received adjuvant chemotherapy for stage 3 18 months ago? So she's still mismatch repair deficient, HER2, 2+. Does that change any of your recommendations? So the same options, what would you choose in this case? So basically all that changed was that she received chemotherapy previously. All right. Okay, so she received chemotherapy previously. People would go to chemotherapy with immunotherapy at this time. Some would give single agent. Some still consider Len-Pem or trastuzumab. Great. Okay, so in this patient, this patient now would fit this category of the second line treatment, prior treatment. And here we see a table of, in the blue are the patients who are mismatch repair deficient. In the pink, it's a patient that are mismatch repair proficient. So we can see that immunotherapy by itself in a previously treated patient is very effective with objective response rates of about 50% or so, 45 to 50%, with long duration of response and very encouraging overall survival. So in contrast, in a mismatch repair proficient patient, we don't see those have good responses. We're only about 13% or so. So for this patient, it would be very reasonable to give her single agent chemotherapy, and we've never compared that to chemo with IO, so we really don't know. We know a little bit about chemotherapy versus an IO combination. This is from the LEAP study, and so the LEAP study included patients with or without prior chemotherapy, and then compared lenvatinib plus pembrolizumab versus carboplatin and paclitaxel alone. So the control arm is without immunotherapy, and we see here that if you give that patient immunotherapy compared to chemotherapy alone, has a ratio of about 0.6 in a mismatch repair deficient. So it's not quite that 0.3 that we saw in the studies that I showed you previously. And this is a mixed bag. And then we see a hazard ratio of 0.57 in overall survival. This is not enough information yet. There's a couple of other studies that are still, we're waiting on results. Keynote C93 compared pembrolizumab versus carboplatin paclitaxel. This is completed enrollment in the DMMR patient population. Hopefully we'll see the results in the next coming years. Dominica is the study, similar study, but with the dostarlimab that's done in Europe. The recruitment is ongoing, and I just heard that they're almost there with the accrual. So these two trials, certainly they compared chemotherapy without immunotherapy. So it's not going to be as informative. We'll likely never see that chemotherapy with immunotherapy versus immunotherapy alone would just take too many patients. But it will still be informative to see if this would be an option for our patients. Okay, so back to the patient. She is now chemo naive again. Develops a lung, multifocal lung recurrence. Tumor biopsy is now pMMR, so mismatch repair proficient. She is P53 mutated, HER2 2+ still. What would you recommend at this point? All right. So in this instance, people are favoring chemotherapy with trastuzumab, some chemotherapy with immunotherapy, and then with bevacizumab is also considered. Good. All right, so here's kind of the comparison of those trials that we talked about earlier already with all the different drugs that have been studied. And we see here, we saw the hazard ratios kind of for the mismatch repair deficient, but on the right side, we see them for mismatch repair proficient. So overall, while not as profound, we still see a significant benefit in the majority of these studies, a little bit more variation. And then here we see with DuoE and Ruby Part 2, where a PARP inhibitor was added to that, the hazard ratios become a little bit better. So chemotherapy with immunotherapy would be a reasonable option, also probably with trastuzumab. I put this in here because this was presented about 2 years ago now, and then there was an update in 2024 where the Ruby trial then classified these patients by molecular subtype. So on the upper right corner, we see the mismatch repair deficient, so no surprises there. What was a little bit of a surprise, I think, when we saw this, that in the mismatch repair, in the mismatch repair proficient P53 mutated population, we saw that hazard ratio there also of 0.55. Now that doesn't necessarily mean that that dostarlimab works a lot better in this specific population, that we should choose this over other options. Again, this is a subset, and those patients in these subsets on the curves, the placebo versus the chemotherapy with dostarlimab, are likely not the same. They were not stratified. So this is very much exploratory, but there seems to be a benefit in all subsets of molecular classes. In the RUBY study, I should say. Because in other studies that hasn't panned out as much. So we still need to learn more about this and see this in more studies. For example, in the MITO-N3 study, so if we look in graph C, this was mismatch repair stable, so proficient, P53 mutated. The blue curve is the curve without immunotherapy, and the red curve is the curve with immunotherapy. So here, the curves are actually reversed. So in this study, they say P53 mutation is associated with a poor effect of avelumab, while mutations in PTEN and ARID1A are related to a positive effect of the drug in patients with advanced endometrial cancer. So a little bit different result, different drug. And then in GY018 that you see in that little forest plot in the right lower corner, we see the effect across all histologic subtypes. And in the serous subtype, we see the bars crossing one a little bit. So more information needed. The general pMMR population, though, we still see a benefit. I think this was I'm going to click through this one. If I can, I can't. This is the same scenario. Except she's HER2 3+. Okay, let's just answer the question. I can't click through it, so you just everybody answer the question, same answers, so we move on. All right, trastuzumab became more of a favorite with HER2 3+, which is very reasonable. I still can't click through it. I may have to borrow yours. Oh, there it goes. So you saw these slides a little bit already. So it's a phase 2 trial. So it's a small study, and it has to be confirmed still in an ongoing phase 3 trial. It included those patients with chemo-naive for the whole study here in the middle. The top graph on the right are the chemo-naive patients, and then the patients who had prior chemotherapy is the bottom right. So progression-free survival of 7 versus 9.2 months. We still see a benefit here, although the bigger difference was in the chemo-naive population. So for HER2 3+, this would also be very, very reasonable instead of immunotherapy. So brings back the question here. So if the patient has had prior chemotherapy, should we go back to chemotherapy again? And this is a pMMR population. This graph is again from the LEAP trial, so lenvatinib pembrolizumab versus carboplatin paclitaxel. There was no difference in the overall population. But when they started looking at all these different subsets, they realized patients who've had previous chemotherapy, whether that was chemo or chemoradiation versus neoadjuvant or adjuvant chemotherapy, we're starting to see a signal that lenvatinib pembrolizumab may be better in the pMMR population, I should say. So here we see this for the pMMR population who had previous neoadjuvant chemotherapy. So we see that lenvatinib pembrolizumab actually is looks to be a little bit better here compared to chemotherapy by itself, both for progression-free survival and overall survival. So should we go back to chemotherapy? Alternatives are also very good, very reasonable. And again, I want to make sure that everybody realizes this is not chemotherapy with immunotherapy. So our control probably has changed with time, but still, and other immunotherapy may be important as well. So here's the real world experience from what we did with a large consortium study, and really looking at that platinum-free interval, because we think about this is like that paradigm of, is the platinum-free interval that we see with ovarian cancer, does that apply in endometrial cancer? And it doesn't. The LEAP study just showed that if you've had prior chemotherapy, probably an alternative regimen may be a little bit better. Here we see in this also that when we compare patients and drawing your attention to the progression-free survival curves to second-line treatment, if you had a longer progression-free survival, longer or shorter, less than 12 months or greater than 12 months, the curves were no different whether you got lenvatinib pembrolizumab or repeat platinum combination. So the longer platinum-free interval is associated with an improved response to second-line treatment, whatever that is, but it doesn't predict an improved response to platinum retreatment when you compare it to lenvatinib pembrolizumab, for example. So just something. So what alternatives, so what other options as this patient who had a prior chemotherapy and was HER2 positive, what other options does she have? We have trastuzumab deruxtecan, BNT323 in development, several other HER2 targeting drugs with these ADCs. And this is promising because 60% of the endometrial cancers are HER2 positive. And we see it more in a serous carcinoma and in those with advanced stage. The circles have moved over. We need to move them just a little bit to the left. I apologize for that. Cervical is highlighted, but to the left, we see the same graphs that we saw earlier on already. This was done in only 40 patients with endometrial cancer, so it's a small phase 2 trial here for just the endometrial cancer population. 22% received prior anti-HER2. A third of the patients had 3 or more prior lines. A third was IHC 3+. And in the overall study population for these 40 patients, the objective response rate was 57%. You see the side effects here, ILD, pneumonitis, about 10-11%. We still see some alopecia. And these are the numbers for the HER2, what the drug got approved on, accelerated approval on, from the prescribing info and based what went on to the FDA data. So instead of 13 patients that they initially reported in the study, they now had 16 patients that were HER2 3+. In that 3+ population, the response rates were 56%, so not the 85% that were earlier reported, with a median progression-free survival and duration of response of 5.8. We see the response rates the progression-free survival curves with HER2 3+, 2+, vary a little bit here. Best response is seen in a HER2 3+. And that resulted in the accelerated approval of this drug, and that was very exciting to have new options here. So I think this slide is serous carcinoma, P53 mutated, HER2 3+. What would you recommend at this point? Trastuzumab, and we're going to click through these because I think the question here. So really this patient should have had, and the question was meant to have that this patient was P53 wild type in this case. So what other options do we have here for these patients that are P53 wild type? And this is from the SIENDO trial. This is not an approved drug, but it's a promising drug that we may have available in the next few years or so. So the SIENDO trial compared or had enrolled patients who had a complete or partial response to carboplatin paclitaxel and then gave patients maintenance selinexor or placebo. And selinexor is a drug that targets the XPO01 inhibitor. And so XPO1 exports tumor suppressor proteins out of the nucleus, and selinexor hold those in the nucleus so it can do tumor or cell repair again. Here, while they didn't see a difference in the intent to treat population, in the p53 wild-type population, at 36 months of follow-up, they saw a 28-month progression-free survival versus 5 months with the placebo. So quite a big difference here. Siendo here, if they looked specifically at the wild-type pMMR population, which is on the left, this difference now went to almost 40 months to 5 months with placebo. So big difference. The confirmatory trial is still enrolling. That is specifically targeting that p53 wild-type population. So we'll have to see if these same exciting results are going to be confirmed in the phase 3 trial, because that was all based on it. All right, let's skip over this one. Can we skip over that? I want to make sure that Dr. Penson has enough time for his talk too. We can go to the next one, please. And please, the next one. Okay, so what else is under development? We have lots of different ADCs under development with different targets: B7H4, folate receptor alpha, TROP2, mesothelin. This is not an all-inclusive list, just some examples of phase 1, 2, 3 trials that are ongoing, and new options that we'll have available to our patients. So how do we think in first-line advanced metastatic endometrial cancer? So really, we have this new treatment paradigm. If patients have a mismatch repair deficient population, whether it's a mutation or methylation, chemotherapy with immunotherapy should be the answer. Or maybe we'll also see that immunotherapy alone would be reasonable. If the patient is mismatch repair proficient and is p53 abnormal, chemotherapy with IO, chemotherapy with BEV is reasonable, and I didn't show you those subsets just for lack of time, with or without IO. If the patient is HER2 positive, then you can also do HER2 targeting with or without IO. If the patient has no specific molecular profile and is HRD positive, maybe we should start thinking about chemotherapy with a PARP inhibitor combination also. If the patient's HRD negative and p53 wild type, should we use an export inhibitor or hormonal combinations? And for the polymutated, observation may be reasonable. So really lots of changes, lots of new options for patients with recurrent endometrial cancer. It's certainly an exciting time, and it's getting harder and harder to keep track of all these molecular things, but really something that we need to start doing early on. Lastly, and this is my last slide, here are some other options that NCCN list. I'm personally a lot less excited about all of these options. Clinical trials are really there to provide new options with promising new drugs for your patients. So highly encourage you to seek one at your own institution or surrounding institutions and give the patient that opportunity. Do want to mention that for those patients who are low grade, and want to avoid chemotherapy, hormonal combinations can be incredibly effective also. So we should definitely not avoid these. A lot of these have less side effects than some of the chemotherapies that we've talked about, whether that is letrozole with abemaciclib, letrozole everolimus, megestrol acetate, alternating with tamoxifen or by itself, newer combinations on trial, letrozole ribociclib. All of those would be reasonable options for your patient, but mostly save those for your low-grade patients. And with that, I think I can hand it over to you.
Thank you very much. It's very good to see you. The interaction is fascinating from our point of view. This is what our peers are doing. So this is actually a patient of mine. This is her CAT scan. I'm going to add a false pleural effusion in a moment. Same principle, a patient I'm going to follow through and change some of the things. So 71-year-old. Her mother had had ovarian cancer at 78, and she lived under this curse, was absolutely delighted to get to 70 and not get ovarian cancer, and then gets ovarian cancer. Stage 3C, high-grade serous ovarian cancer. And actually, we tested her. She was convinced she was going to have a BRCA mutation, did not. She was actually HRD negative, her tumor was. And we said with absolute MGH confidence, we're going to find your mother's tumor. She was operated on by Arlen Fuller, pull it out of the bank and genotype it, and I'm sure there's going to be an explanation. We couldn't get the DNA out of the tumor. She has that CAT scan, a bigger mental cake, ascites, and a partial response. How do you treat her? What would be your optimal choice? She has a BRCA wild type tumor, HRD negative, high-grade serous cancer. Platinum-based chemotherapy. Number 2, platinum-based chemotherapy with bevacizumab, concurrent and maintenance. Number 3, platinum-based chemotherapy followed by a PARP inhibitor as maintenance. Number 4, platinum-based chemotherapy with bevacizumab followed by bevacizumab and olaparib maintenance, or niraparib if unable to tolerate olaparib. See, I'm going to be split on so many of these things. So bevacizumab maintenance, PARP inhibitor maintenance, just under 1 in 5 choosing the payola-1 regimen of chemotherapy with bevacizumab followed by anti-angiogenic and PARP inhibitor together. Fascinating. So we're back to the case. I've highlighted the things so it is obvious now. HRD positive, so not a BRCA mutant tumor, but the tumor is more sensitive to PARP inhibitor. Same combinations, chemo, chemo-bev, chemo-PARP inhibitor, chemo-payola-1. Should I do the music?
Ready?
So having an HRD tumor really does make a difference. You really hope it makes an overall survival difference. And PARP inhibitors really do carry the day a lot in people's minds. So the next scenario, we changed it so she has inherited a germline BRCA mutant tumor. Tumor is HRD positive, but again, nasty tumor, and she has a partial response. What do you do? Platinum-based chemotherapy, bevacizumab, PARP inhibitor, payola-1. PARP inhibitors still carry the day, 55% platinum-based chemotherapy and switch maintenance PARP inhibition. So we changed it still. She now has, I'm going to just buzz in the pleural effusion. That was, no, actually she didn't have one of those. We're just going to imagine she had stage 4 disease with cytologically positive pleural effusion, germline BRCA mutation, HRD negative. I don't think I wrote that slide right. So the options exactly the same, platinum-based plus chemo, plus bevacizumab, or PARP inhibitor, or the combination of anti-angiogenic and PARP inhibitor. So the payola-1-like combination or Vario with niraparib, much more popular, overall survival advantage with stage 4 disease using bevacizumab, substantial 13-month. So that does swing the day for that, and I think quite appropriately. So stage 4 disease, HRD positive, does that swing you back towards a PARP inhibitor? Pleural effusion, stage 4 disease, your chance to choose one of those 4. split, 44, 47%. It's really hard to know. I do have a bias, and I think I'm going to try and get through the presentation quickly so that we talk about that. But tailoring it to a patient and having these options is really exciting. So maintenance therapy, we're going to talk about high-grade serous cancer, where it's bevacizumab or PARP inhibitor or both. But just to remember, a lot of these things are changing. Low-grade serous and low-grade endometrioid, aromatase inhibitors being looked as adjuvant maintenance therapy, clear cells and mucinous tumors, really getting to the molecular underpinnings of things, bevacizumab, a HER2 antibody or antibody-drug conjugate, checkpoint inhibitor for deficient mismatch repair. And the nice thing is we have this amazing data pool for bevacizumab or PARP inhibitor or both, and that's what we're going to really look at. And just to remind you that with the CA125, the first season of hope is for cure, and impacting overall survival at that time gives you the hope for cure, not just prolonged survival. And so this is a beautiful review from 2021 that I don't think has been better, and divided up the determinants like this. So comorbidities, how sick is your patient? What's their age? Do they have other comorbidities that might be significant, or thromboembolic disease? About half of our patients are sick, amber light. About 10% really have to tailor treatment to near moribund patients who present. And stage is important, maybe 1 in 5 with early stage disease, but it's advanced stage disease. And we really do think about stage 4 disease differently. It's about maintaining control of disease and, as we said, overall survival with bevacizumab. Clearly, surgery used to be primary cytoreductive surgery. At least at MGH, half of our surgeries are after neoadjuvant chemotherapy. But you're much more likely to have a R0 resection with primary cytoreductive surgery. And we're talking about high-grade tumors, the majority serous, but other types are going to dictate options. And then, as Pam said, genetics really important, maybe 20% BRCA, half BRCA or HID, and then homologous recombination proficient tumors in the other half. About 10% are going to be refractory. And we think of these seasons, first-line therapy, lots of options, platinum-sensitive recurrent ovarian cancer, platinum-resistant, and then maintenance in both of these two settings, still a really important part of care. We very much think of ovarian cancer now as 2 diseases. The standard ovarian cancer, where surgery still plays a role, maybe in recurrence as well. Niraparib is indicated in that when there's not a biomarker-driven choice, and bevacizumab seems to work at every stage. We used to think about the platinum-free interval, but now our choices are really dictated by histology, genetic signature, treatment-free interval, and the number of prior lines. In contrast, BRCA-mutated ovarian cancer has a much better prognosis, and PARP inhibitors have been integrated first line, second line, later line, with anti-angiogenics in first line and recurrence, and now increasingly with immunotherapeutics as well. And just to drive home the message about how different these 2 diseases are, I'm going to do a classically bad thing, an overlay survival curve. So GOG 218 with bevacizumab, and then if you put the solo 1 olaparib curve with patients doing so much better, not really educational because these are very different populations of patients, and the placebo arm, a third of the patients on solo 1, clearly outperforming the patients who were enrolled to 218. They were different patients. Every single patient had a BRCA mutation, and you are pulling out the patients who are going to perform best from those 2 studies. If we look at the approvals from 2014, olaparib was the first based on study 42, and then rucaparib study 10 and Ariel 2. And then niraparib was the first to be approved for maintenance therapy based on NOVA for second-line therapy. And then a real education as our experience with these this option changed. Rucaparib was the first to have a voluntary withdrawal in patients who'd been treated for more than 2 lines, based mostly on Ariel 4, then olaparib on 3+ lines from Solo 3, and then niraparib for 2+ lines. So this was the pharmaceutical companies withdrawing after discussion with the FDA, and then the FDA started to get more concerned, and actually I think AstraZeneca were going to try and hold out for study 19, but there was a push. In the end, finally AstraZeneca caving, and all of the indications for second-line therapy requiring a BRCA mutation So the way we think about this for US studies, first line, solo one, payola one with bevacizumab as well as olaparib, Prima for niraparib, and Athena for rucaparib. This is the design of the study, placebo-controlled PARP inhibitor trial with primary endpoint progression-free survival. And generating options like we're doing in endometrial cancer, really the goal. These are the progression-free survival advantages for the peer-reviewed published data to date. You may not know much about sinaparib. It's not available in the US, but this is a beautiful publication from Nature Medicine. And look at the hazard ratios, 0.3, 0.4, 0.33, 0.4, 0.43. For these BRCA mutated tumors, the progression-free survivals are all very, very similar. They're all very similarly effective drugs. I haven't mentioned Prime, but Prime was the Chinese equivalent of Prima and showed very similar effects. If we look at Prima, this is the study that really took us into this domain of homologous recombination proficient patients. So our patient was this one, BRCA wild type but HRD, and really drove a lot of excitement that this opened access to everybody, a non-biomarker driven benefit. But the greatest benefit from niraparib treatment was seen in patients with HRD tumors that were BRCA mutated, the top left group. And so currently in the US, olaparib is approved with as a single agent or with bevacizumab, niraparib for all groups, and then rucaparib is not available as a first-line therapy. Looking at Solo 1, where those survival curves touch at about 3 years, it's really tantalizing to see why did they open so much later? Was 2 years rather than 3 years important? We really don't know why this outcome was so good. This is a 45% better overall survival at 7 years, which is quite remarkable, and all the more remarkable because 44% of patients in the placebo arm crossed over to a PARP inhibitor with future treatment. For Prima, these are those three groups, the overall population in the top left panel, HRD, and then HRP in the front, and there was not an overall survival for any of these groups. And why that is really not clear. So crossover, because people are learning more about the use of PARP inhibitors, increased from Solo 1, 44 to Prima, 58%. The length of time was longer. Maybe this really does drive more reversion mutations and bone marrow dysfunction in the future. And dose reductions, dose interruptions, and dose discontinuations were also higher for niraparib. So something in these may explain it, but it may be more complicated than that. So back to our case, the patient has a partial response to carboplatin paclitaxel, and due to her hypertension and personal preference, she opts for a PARP inhibitor, and she started on niraparib maintenance at 200 milligrams a day. And after 1 month of niraparib treatment, routine blood work reveals a platelet count of 65,000. How would you manage this patient's maintenance therapy? Continue niraparib at the same dose, continue to monitor blood counts weekly, reduce dose of niraparib to 100, discontinue maintenance therapy, or switch to a different PARP inhibitor. Yeah, reduced dose to niraparib to 100 milligrams. I remember sitting down with the boss of the team who owned niraparib as they changed over to GlaxoSmithKline, and it was really interesting how poorly we define doses, and we do not know the effective dose or the thresholds for too low a dose for too many of these. I reduced somebody on trastuzumab deruxtecan the other day, and the pharmacy rang me up and said, "There's no data on half-dose trastuzumab deruxtecan." So I want to really drive home this message pictorially about how much PARP inhibitors are a concern for later line therapy. So on this bar chart, I put Solo 1. That's a 45% improvement in overall survival, and these are overall survival magnitudes. First line therapy, hazard ratio of 0.55. And then it was my privilege to serve as the PI of SOLO-3. And these are the SOLO-3 data in which second-line therapy definitely improved overall survival, a hazard ratio of 0.83. It did cross unity, so we can't say it definitely did. Third line, a 20% reduction in overall survival and a worse hazard ratio. Fourth line, a 58% worsening of overall survival. And so if you sum that together, as we did in the publication in JCO, 3+ lines hazard ratio a third worse. That was almost exactly the same for niraparib and for rucaparib. And so really consistent hazard ratio is something that the FDA very much took notice of and appropriately chaperoned the withdrawal of indication. So when we think about PARP inhibitors, I tend to tell patients, fatigue, nausea, and a 1% risk of leukemia, which is not on this list, but this is a more expanded list. And there are nuances between the PARP inhibitors, but they are relatively similar in the side effects that they have. Relatively hard to show quality of life differences between or even after PARP inhibitors. If you look at the safety of PARP inhibitors in frontline therapy, if you go down to the fatigue scale, all pretty similar. Thrombocytopenia quite different for niraparib, but relatively readily manageable. And then the liver dysfunction, much more common with rucaparib. This just expands on that and says the same sort of things. And just eyeball the difference between clinical trial and real-world data. It's amazing how useful some of this Flatiron data is about how much toxicity people get. And so there's very little data on using less than 200 milligrams of olaparib. Reducing from 300 to 250 to 200 is the normal thing. And then niraparib changed in terms of how it was used, and many people use 200 milligrams as the starting dose. You can easily go down to 100. Rucaparib's now not available. The radar analysis of what we call weights and plates, weight less than 77 kilograms, platelets less than 150,000 per microliter, really did change things. And if you look at the green bars to the right, the first one, full dose, and then the other one, the individualized starting dose, a big reduction in the risk of side effects or the need for interruptions and dose reductions. What you may not have seen, though, is the hazard ratios. And so the fixed starting dose hazard ratio, 0.59 in NOVA, and then the individualized starting dose, 0.69. So one of the real concerns is that we may, with 3 years of niraparib, expose more bone marrow toxicity for a slight reduction in the efficacy, though the way this was concluded in the paper, it was felt that these were very similar outcomes. I want to pick through this slowly. So we're going to go down each of the columns. We've just resubmitted the AML-MDS paper for SOLO-2. And so if you look at that first panel, previous systemic therapy, you can see the odds ratio for developing AML-MDS. This is a really good paper in Lancet on Hematology. So just one prior line of therapy, odds ratio of nearly 2, 2 or more, an odds ratio of approaching 5 of getting leukemia. If you look below that, going on for more than 2 years had a much higher rate, though there just wasn't enough events when people were treated for under 2 years. And then below, you get the challenge with these terrifying but rare complications. And so those different durations, a year to 18 months, a year and a half to 2 years, or more than 2 years. You can see those hazard ratios are all over the place. I don't think anybody thinks that a shorter duration of PARP inhibitor is any safer. And then at the top of the second column, the PARP inhibitors, those are all very different. And the only thing you should look at is the confidence intervals of those numbers. They are too big to draw any conclusion between the drugs. The biomarker specificity in SOLO-2, it was increased from 4 to 8% leukemia risk when it was treatment to progression. And so BRCA mutations really do drive much of the risk, as much from prior platinum as from the PARP inhibitor. And then again, they're setting first line. Maintenance for second line beyond really is confounded by the duration of exposure. And then PARP inhibitor assignation. I don't think bevacizumab spares any risk of leukemia, and you should be cautious about your interpretations of that. A lot of people think these drugs are not cost-effective, and that is not true. So our three options, niraparib, olaparib, and bevacizumab, in the NCCN guidelines, which are really quite helpful. I'm going to look at those purple boxes in a second. We're talking about niraparib for all comers when you're first treated with platinum. The concurrent use of bevacizumab with chemotherapy, and then rolling on if you have an HRD positive tumor with an overall survival advantage, bevacizumab or bevacizumab and olaparib, and then for the HR deficient upfront treatment, olaparib. In the purple boxes, you will read olaparib versus maintenance therapy is cost-effective for patients with BRCA mutations in that top purple box. Second purple box, niraparib, is also cost-effective for HRD positive patients. And then the bottom one, olaparib and bevacizumab, a staggeringly expensive regime, is cost-effective for progression-free years saved or months saved in the HRD group. This is a really nice publication that summarizes all that. So cost-effective therapy with a significant impact. Back to our patients. The patient's dose of niraparib is reduced to 100, remains on treatment with stable disease. How would you treat this 71-year-old patient with grade 3 high-grade serous ovarian cancer if she had BRCA wild-type HRD positive disease? I'm going to just do this again after seeing the data. Platinum-based chemotherapy with bevacizumab, followed by a PARP inhibitor or the PAOLA-1 or Ovario treatment. Well, that's fast, but I think you saw it. The combination, thank you, at the end, PAOLA-1 or Ovario. Yes, that's exactly right. And so I'm going to do a second time a really horrible thing, putting two curves side by side, PAOLA-1 and the HRD patients to the left, to the right, prima niraparib. This is overall survival in the HRD population, same populations. And if you overload those curves, you might say, well, that was a different drug, didn't they do well? This group got bevacizumab, so we really don't know why prima didn't translate into an overall survival advantage, but that really has driven much of the choice for HRD positive disease. This is the PAOLA-1 bevacizumab plus olaparib in the intention to treat group. Overall survival really not different, crossing unity, as opposed to the HRD positive tumors with a BRCA mutation, thumbs up. Patients with a BRCA mutation, that is a tumor BRCA mutation, and then HRD positive tumors, excluding those with the BRCA mutation. Again, overall survival advantage in contrast to the HRD negative tumors. Ovario, very similar data. It's a really nice combination. We don't use it that much, but it's definitely something you can use, and is a really nice cocktail. The first study includes an immunotherapeutic into that Ovario-like cocktail of niraparib following chemotherapy. Of the prima and prime combination using dostarlimab with niraparib. And there's a lot of interest in this. You saw that interest in endometrial cancer. Excuse me. With the PARP inhibitors approved in the first line, they closed that arm. And we're excited to see the results that are not yet available. We have seen the results of DUO-O, which is the same sort of thing from AstraZeneca, now using durvalumab with olaparib. But unfortunately, because of the way it was designed, that top purple curve is immunotherapy plus olaparib. Looked like they did a lot better, but excuse me. But it really looked like olaparib was making the difference rather than durvalumab improving the outcomes with bevacizumab. So, polling question. 16 months after completing her primary therapy, while on maintenance therapy, the patient develops bilateral pleural effusions. Imaging revealed the presence of disseminated pulmonary metastases and found to have high levels of folate receptor alpha. How would you manage this patient now? Chemotherapy? Chemotherapy plus bevacizumab, bevacizumab alone, or mirvetuximab, soravtansine. Oh, that's a trick question. It's 16 months. Platinum-based chemotherapy with bevacizumab is likely to have a better outcome, even though mirvetuximab soravtansine 4-month better overall survival in platinum-resistant disease. How would you manage the patient if she developed bilateral lung metastases with high levels of folate receptor alpha 4 months after completion? Chemotherapy alone, chemotherapy plus bevacizumab, bevacizumab alone, or mirvetuximab soravtansine. There you go. What a teachable crew. Good job. So I just love this paper. When I read this paper, I thought, I can write a review paper. This is the way to think about things. So that was the paper that I showed you with determinants of first-line therapy. Now determinants of subsequent therapy. Stage and surgery have really changed to medical therapy. Platinum-free interval, less than 6 months platinum-resistant, more than 6 months potentially platinum-sensitive, and then PARP inhibitors and bevacizumab still potentially, but as we said, PARP inhibitors only if you have a BRCA mutation. Clinical trials, as Flor said, really, really important. And then surgery for oligometastatic disease. If you look at the genetics group, the big difference is about a third of patients are going to have reversion mutations, which really you need to know before putting people on subsequent trials, and all too rarely we do. And then that platinum refractory group, the resistance really increases, and quality of life is all important. And finding those things that make patients sensitive, folate receptor alpha, HER2, or deficient mismatch repair in recurrent disease are really important. Lots of options for platinum-sensitive and platinum-resistant disease, and lots of change in our understanding about things. But mirvetuximab soravtansine, really an exciting new option that not only improved response rates, progression-free overall survival, but improved quality of life. It's so rare we see all of those. Really impressive improvement in progression-free survival and overall survival, which is just fantastic. So things have really changed in terms of the clinical trial programs. Beyond PARP inhibitor, WEE1, ATM-ATR inhibitors, CHEK1 inhibitors, poly-ADP ribose glycosylase inhibitors, and PARP1 inhibitors. That whole biology is just exploding, and how we integrate that with immunotherapy is sort of the new frontier. Antibody-drug conjugates, targeting p53, the holy grail with some of the new drugs, which is very exciting. Anti-angiogenics still in the mix, and how we put it all together is really the challenge. Pam.
Thank you, everybody. We even left time to spare, so good job. So I don't think we have any questions from the audience, at least on the iPad. Are we allowed to have questions, live questions from the audience? Does anyone want to ask a question?
Would you field a question from me?
Sure.
So I had a patient just like one of the Flor's patient earlier on, who was everything positive. Do you know, she had deficient mismatch repair, she had HER2 disease, she had folate receptor alpha, she had recurrent endometrial cancer. And so I emailed Amanda Fader and I said, okay, what should I do with this patient? And she emailed back, put her on a trial, which was a great answer. But didn't really nail for me what I needed, because it gets so complicated. And I was curious about those sort of patients where you have all of the choices. In your mind, Flor, do you have a prioritize? Is immunotherapy early the first, is there a way you think about it?
I mean, yes, if there's a trial available, that's the easiest answer because I don't have to answer them which one to just get the randomization, and both are good options. But I think the hardest population, the DMMR, like we were saying, that patient that's HER2 positive and 2+ or 3, especially if they're 3+, what are you going to do? Are you going to, and she's advanced recurrent, are you going to give this patient now chemotherapy with immunotherapy or chemotherapy with trastuzumab? That's really, I think that's the question that we struggle with in our tumor board all the time. And truthfully, I don't really know the right answer. I think it's very reasonable to put this patient on, especially if they're chemotherapy naive, on chemotherapy with trastuzumab. And then your next line of treatment can be lenvatinib, pembrolizumab. The patient is still going to get immunotherapy, and they should get immunotherapy at some point. Is it better to get immunotherapy with chemotherapy at that point? I don't think we don't have that answer yet. And maybe for that patient, we're going to see that patient actually, instead of chemotherapy, should get a HER2 targeting drug. Who knows? Like, the field is changing and we need to do more studies. But I think that's probably the trickiest situation to be in, absolutely.
Yeah.
Yeah, I think the only thing I would add to that is it's so nice to have so many options, right? Because I think 5-7 years ago, we were treating everyone with Taxol Carbo, maybe adding certain things. So I think now we're thinking about, we have all these options, like how do we sequence them? I think for me, I try to look at the data and see, is there something that showed an overall survival advantage, and that maybe I would give that first. But I think, these are scenarios that come up often and we have to make those decisions.
Yeah.
And I think what you're saying there is actually a really, really good point. And we do talk about yes, you have the trastuzumab. When we refer to that, we have to remember that is the small phase 2 trial. And we do have several trials available with immunotherapy combination at our phase 3 randomized trials in big populations. So that would also be very reasonable to slide your patient then to go into the chemotherapy, immunotherapy first. Absolutely, yeah.
So Richard, I was going to ask you a little bit about sort of the Payola-1 study. So I think we all know there's like a missing arm, or for a lot of these trials, we learn something kind of along the way. So for your patients that are either BRCA mutant or HRD positive, how do you decide which patients you just give Taxol Carbo followed by a PARP maintenance, or how does the bevacizumab?
Right. So in the US at the moment, about a third of patients get bevacizumab as part of their frontline therapy. And the only place where there's an overall survival advantage is in stage 4 disease. So I think the way the NCCN guidelines are written has changed to reflect that the first decision is to use bevacizumab or not. And then it's what do you add on to that later, which I think makes it a relatively easy sort of choice. So stage 4 disease gets bevacizumab. Imagine a patient with a BRCA mutation who has stage 4 disease. You might start with the bevacizumab including in your cocktail to give you the best chance of doing really well. And you might drop it once they're in remission, they have a partial or complete response. There was not enough time to go into some of the granular things, but if you look at the patients with partial responses, SOLO-1 is one of the 3 trials where the patients who had a partial response, there was actually a bigger benefit from being on a PARP inhibitor. So clearly, if you have a partial response, you're not going to get cured, but the relative survival advantage was greater in comparison to the third of patients who did not get a PARP inhibitor. So personally, I think trying to get to a CR is really important. So if somebody had a BRCA mutation and they had a terrible disease, I might try to get them to a second surgery if they have a nice response. Try to get them to the CR where you hope they might get a cure later.
So I would also ask, so in patients that are kind of beyond PARP, I know you briefly mentioned sort of the kind of other trials that are upcoming. Where do you think kind of our biggest push should be, both in ovary and in endometrial cancer?
Beyond PARP inhibitors.
Beyond PARP inhibitors.
Yeah, so I think the experience to date has been that combining DNA damage response agents is really challenging. There are many agents that have floundered with complications of neutropenia. And so working that out is, I think, really challenging. So, an ATR inhibitor timed at the right point with the PARP inhibitor could be beautiful science, but is really challenging to do. And so we have put most patients recently on the Fontana trial, in which you use an antibody-drug conjugate with a PARP inhibitor. So you're using, and that's a PARP1 inhibitor, saruparib. So what's really nice about that is you get slightly less hematologic toxicity. You're exploiting this perfect window of trying to get into the narrow therapeutic window with an antibody-drug conjugate, 2 or 3 times as good as chemotherapy in most of the trials, and non-overlapping toxicity. So you really can cocktail things together with surgery and immunotherapy.
So what about, you mentioned sort of PARP resistance and then PARP combinations. For patients that have a germline mutation or you give PARP inhibitors as primary maintenance, and then they recur later, do you consider retreating them with PARP maintenance, for example, like in a BRCA patient?
So in the Oreo study, we don't actually know. So that's that trial. It's our one trial looking at rechallenge with at least 6 months in between. There was 10% of patients who got an extraordinary benefit. And so this is pre the awareness of MDS, AML. So it just was constant PARP inhibitor. I took a patient off after 9.5 years of being on a PARP inhibitor once this all came to light 2 or 3 years ago. And it's really tempting, and it's so hard to pick out that patient. Reversion mutations are a large part of it. It's about a third who really don't get any further benefit. So our policy now is to biopsy everybody, and it's not difficult to find reversion mutations with next generation sequencing.
Okay, so that's how you determine whether to retreat?
Yeah, I think so. If they haven't got a reversion mutation, having another try at a PARP inhibitor is worthwhile.
Yeah. And I would add to that, then I do the same thing, like biopsy them, make sure that they still have a potential of getting that benefit again to get retreated. But it's also not that hard for our hematology colleagues, or at least I've worked with our hematology colleagues then, to refer them to them, especially those BRCA patients that you pointed out after PARP. Those are the ones that have the highest risk of AML, MDS. To get them analyzed for if they have any CHIP mutations in their blood that can increase their risk further. And if they do, and now all of a sudden, I've had a patient who then was quoted to have about a 40% risk. So like, okay, we're not going to go back to PARP in this case. But yeah, that was in a BRCA mutated patient. So for those patients that are already at elevated risk, that's another option if you safely want to retreat.
Yes.
Yeah, to add that.
CHIP is really complicated.
Yes.
And so I've stumbled over CHIP in patients who do really well. So I had a patient who was on the abemaciclib letrozole metformin trial, got a CR, and then she wanted, a tumor DNA testing, circulating tumor DNA testing, and she came up with a P53 mutation. And she felt like cursed that she was going to get a recurrence soon. I said, you've almost certainly got this clonal hematopoiesis of indeterminate prognosis. And we don't know. It was so hard to persuade her not to go on to chemo with immunotherapy because she wanted to live forever. CHIP is really complicated at the moment, and you're right, you need other colleagues to sort of add to your wisdom. And some of the assays are better than some of the other assays at excluding CHIP based on Buffy code analysis.
Okay. So Flora, I think one of the challenges as we move immunotherapy up into the front line, specifically with patients that are mismatch repair proficient, if patients recur shortly after while they're on immunotherapy, what is your second line? Because I think before we were giving immune checkpoint inhibitor up front, I think most people would then go to len-pem as their kind of go-to second line therapy. So how has moving it into the front line changed your option for a second line, or do you still go to len-pem in those patients?
I'm just very thankful for the ADCs that we have available now. I was saying earlier, I was sitting in a meeting earlier today, and with the amount of immunotherapy that we're using up front, certainly the len-pem regimen, we're using less. I have off-label added lenvatinib to see if you can elicit a new response again. It does work for some patients and it doesn't work for everybody. So whether that's the best way to go, probably not. Like looking for an ADC, there's so many targets, and a lot of these targets actually are quite prevalent within endometrial cancer patients. Some of those I mentioned already. That gives them the opportunity to now get a completely new drug with most of these, either with a tubulin targeting with a DM1 or with an exatecan topoisomerase inhibitor like drug to get that drug. And I think that's probably the most promising where we would go next. If not, yes, they're going to end up with weekly paclitaxel or sometimes doxorubicin when those trials are not available, and we just don't have really good things for that mismatch repair proficient population right now.
Okay. Well, I think we're running out of time. So I want to thank everyone for being present, for those here in person, also those online. I think hopefully we've convinced you that doing biomarker testing really early in patients with both endometrial and ovarian cancer can really significantly impact the choices that we make for treatment. And thank you all for being here tonight.
Thank you.